And Jeff, go ahead and take us away.
I will. Thanks, Natalie. And Alki, thank you again for joining us for this webinar. I have a few charts that I'll go through just as a quick introduction on Diagnosys and our system. Some of you are quite familiar with our products, but we have people joining us who don't currently have Diagnosys systems, so we'll do just a quick overview before I turn things over to Alki. Our company, Diagnosys, was founded in 1984, so we're about 36 years old now. We have office locations outside of Boston, which is where Natalie and I are located, also in Cambridge in the UK, where Anna Rosa and Richard Robson, Liam, and the rest of our team are. And we also have an office in Dublin, Ireland as well. And then distributors throughout the world. So in North America and in Europe, we work pretty much directly with all of our customers. In Asian countries such as Japan and Korea, Taiwan, Hong Kong, China, others, we have very good distributors, as well as in India, Australia, New Zealand, and quite a few countries in South America. And that's always growing. As we see new customer demand, we work with new distributors as well. Our product lines then cover 4 broad fields as we look at them. Electrophysiology, we have a number of psychophysical tests as well, pupillometry, as well as objective visual acuity. And that's shown on this chart amongst other imaging technologies such as fundus, OCT, and visual fields. We think of our products in a couple of different ways, but this is one way to think about them. Subjective and objective types of tests in terms of do we need patient responses or not during the test. We have an objective test of estimating visual acuity called sweep BEP that I'll talk a little bit more about. On the bottom row, we have subjective tests that are psychophysical tests, FST, and dark optometry that run on our systems, and then objective tests, including a full suite of electrophysiology tests, and then pupillometry as well. Our products look like this. We have 2 main product platforms. One we call the E3, that's a desktop-based family or system. And we also have what we call the Profile series, and that's a cart-based system. Both of these product lines use state-of-the-art technology. They both offer the same full range of tests, full range of stimulators. They're just different form factors set up for clinics in giving you the option of either having an all-in-one integrated cart or a desktop system that you can place on your own table. The 5 primary stimulators that we have today are shown in each of these sets of pictures. The Color Dome and Color Burst are right here. Those are Ganzfelds, a binocular and a monocular Ganzfeld. We also have the ColorFlash, which we'll talk quite a bit about today. For pattern stimulators, this little guy right here we call the Envoy. That's a monocular OLED stimulator that it's used for PERG and pattern VEPs. And then we have our larger binocular LCD monitor that's used for multifocal ERG as well as pattern VEPs. And we'll talk quite a bit about pattern VEPs today in Alki's talk. Across these platforms, then we offer all of the ICEV protocols, both the standard protocols as well as the extended protocols, and those are always growing. And a library of dozens, probably 100 or more custom protocols, and we're always happy to work with customers to create additional custom protocols. That's one of the big strengths of having one of our systems. Our software allows quite a bit of tailoring of protocols. And then we offer upgrade modules as well, including the Diagnosys FST, dark optometry, sweep BEP, pupillometry, and a newer module called the electrically evoked response module as well. All of these systems and our animal systems, which I'm not showing here, run on one software suite, which we call Espion. This is, I'm not going to go through all of these. This is a fairly full list. It may be the full list of current ICEV standards across all of the electrophysiology tests that ICEV has standardized for clinical use. These are all offered on our systems, as I mentioned. ColorFlash, so just a couple of background charts. Alki will talk more about how he uses our ColorFlash in his clinical practice, so I'll give you a bit of background before he goes through that. The ColorFlash is a high luminance flash stimulator. It has red, green, and blue, as well as white LEDs, so that gives you the ability to do a full range of individual colors and mixed colors using the stimulator. The luminance range in white ranges from 0.01 candela-second per meter squared up to a flash strength of 1300 candela-second per meter squared. So quite a wide range for a handheld stimulator. That might be and I think is the largest range of flash stimulus that you can get in a handheld today. We designed this with a couple of purposes in mind. One was as a replacement for the Grass PS2 strobe stimulators that many people had used for decades. And Alki will talk more about benchmarking work that he had done earlier this year comparing the ColorFlash to the Grass strobe, which he had used for many years. He's published that in the paper that I show here. The ColorFlash connects to any Diagnosys E3 or profile system. You can also buy a flash stimulator switch box. Early next year, we'll have this released. If you have a current Diagnosys system, or if you currently have a Diagnosys system, along with a color dome and or a color burst, if you buy a ColorFlash as well, then you can plug those all into the switch box and then just switch between the stimulators. This can be set up and used either as a handheld or a tabletop, as shown in the pictures over to the right. Handheld on the top, tabletop on the bottom. In addition to the stimulus paddle, then we have an integrated speaker as well as a trigger. The trigger can be used to manually trigger flashes as well as sounds and fixation lights as well that are used for attention purposes on the stimulator. So why use the ColorFlash stimulator? A couple of examples here. One, and maybe first, is pediatric ERG and VEP. This is what Alki will go through today. Testing young children anywhere from 30 centimeters to 3 meters. 30 centimeters is somewhat of a nominal distance. It's the distance we've used for the normative data that we've put together so far. You can bring your patient closer if you choose, and 3 meters is basically the limit of if you stretch out all of the cables, the amplifier cable, your electrode cables, and the ColorFlash cable, you can get a patient about 3 meters away from the ColorFlash itself. So the flash is quite bright, and it's intentionally so. If you have a patient who's not very cooperative and not willing to sit still, you can still flash with the ColorFlash. Attention-making sounds and LEDs, I mentioned already, those are there for attention purposes. World's brightest flashes. And then we do have an initial normative data set that's been developed with skin electrodes using undilated patients that Alki has worked with us on, and he'll talk about that protocol in his presentation today. You can also do Diagnosys FST for low vision patients on the ColorFlash, so you have the ability to test light perception and even no light perception patients. The range of red and blue flashes that we can do on the ColorFlash are actually about 20 times higher than what we can do on the color dome. So if you're doing FST with very low vision patients on your color dome, the ColorFlash can complement actually the FST that you do on the color dome. And we're happy to talk a little bit more about that with you if that's of interest. Contactless ERG and VEP, what I mean by that, we still have electrodes, so those are in contact with the patient. But the stimulator itself obviously doesn't have to be in contact, as is typically the case with a Ganzfeld stimulator. So you can test near 0 centimeters, or you can move further away from the patient as well. And then finally, neurology applications. This is something we're going to work on next year, probably early next year, is partnering with EEG companies that offer EEG systems and oftentimes want to add a stimulator onto that system for ERG and VEP tests that are enabled in their system. So that's work that we've done in the past, and we're going to restart that early next year using the ColorFlash. And then finally, just a quick chart on Sweep VEP. This is useful for adult and pediatric patients as well. The Sweep VEP method that we use is based on work that Michael Bach had done at Freiburg University about 15 years ago. And one of his first publications is shown on the left in 2008 on this method that he developed, proved out in testing many hundreds of patients in Germany. Those were adult patients. Our goal then a couple of years ago was to emulate that method, and we worked with Michael to do so, to port over his method onto our system. Michael and I then did a benchmark study of Diagnosys system performance versus some of the work that he had done previously. We published that last year. And today then we have a fully automated system that takes a few minutes to run per eye, fully automated. Typically you're working your way through 6 check sizes per eye, and then the software will automatically estimate visual acuity that can be in imperial units, standard English units, and decimal or logmore equivalent units, estimating the acuity of the person on a per eye basis, and then giving a confidence level as well. We're just starting to work on this method with some of the pediatric hospitals. Pediatric applications was not the original intent that Michael had when he developed the method. And so we've been working with a couple of customers closely to benchmark this method for pediatric use as well. Those are my introduction slides. So with that, Alki, I will turn things over to you. The floor is yours.
Okay, Joe, thank you. And thanks, Natalie, for asking me to give this talk today. Is it moving the slides forward?
The pointer is moving. There you go.
There you go. So Jeff's alluded to these ICE standards that are very important for us when we're doing visual electrophysiology. It enables us to standardize our stimuli and our recording techniques, and also enables people to go from one laboratory to another and ensure that we have similar results. One of the things when we talk about pediatrics, it covers newborn babies up until adolescents and 18-year-olds. And obviously the investigations that you can do in a cooperative 15, 16-year-old is completely different to what you can do in a younger child. The presentation of the children are also quite different. By the time they become adolescents, we usually know where the visual dysfunction is, whether it's in the retina, optic nerve, or visual pathway. And because of that, we can choose appropriate investigations to answer the question that the clinicians are asking us. For example, if you've got a retinal pathology, you may maintain and record the ERGs, either the full field, the multifocal. In comparison, if a child's got a question of raised intracranial pressure, we may do visually evoked potentials. It gets a bit trickier when we are looking at younger children. A lot of the children and infants that we see may come with unexplained visual loss. And because of that, we don't know where the site of pathology is. And the decision to go ahead with maybe ERGs first or VEPs sometimes can be a bit difficult to work out. But in these infants, they may have, like I said, reduced vision, unresponsive to amblyopia therapy, and the very little tiny babies may have fixing and following problems. They may have unusual eye movements, or they may have a known congenital abnormality like a corneal opacity or cataract. And again, we need to consider which investigations we do first. So what I'd like to do now is go through a protocol that was initially set up by Tony Chris at Great Ormond Street and used by Dorothy Thompson and myself while I was there, and what I brought over to Pittsburgh. And what we usually do is we try and do the least invasive investigations first. And what we find is that recording the pattern reversal visually evoked potential seems to be the least invasive. So while the child sits on a chair and looks at some kind of fixation cartoons, we're able to put electrodes on without much fuss. That's not always the case. But just by doing this test, it provides us a lot of information. It gives us information regarding macular pathway function. It gives an electrophysiological measure of vision. It quite easily identifies intraocular differences. And typically in a cooperative or semi-non-cooperative patient, we can do these recordings, both eyes open and then each eye individually within about 20 to 25 minutes. As we all are aware, the pattern reversal has a very stereotypic waveform, the P100, what we measure, and we usually record responses to different check sizes. Again, the reason we use it, it has a very detailed and predictable maturation. And on the right-hand side, we can see the latency of the P100 to 50 minutes of our check, and we can see how quickly that latency changes. On the left-hand side, we have the waveforms. Again, some more data showing how the P100 develops, becomes shorter in latency and better defined, and then at around 7 months of age is near normal values. What's also important about the pattern reversal visual evoked potential is that although there's considerable inter-subject variability, there seems to be less intra-subject and inter-visit variability. And on the left-hand side here, what we see is the amplitude and latency of the P100 carried out every day over a 25-day period. And what we find is that the variability of the amplitude, the standard deviation, is about 20%, and the change in latency is about 4%. And if we have this measure in our mind, if we're monitoring somebody who's coming from visit to visit, if they start to fall out of normal limits, we're able to identify that. So any system has its inherent noise where the responses get bigger and smaller, bigger and smaller, but you should be able to see somebody who drops out of these, out of that range. This is an example of a child who we were monitoring with cranial synostosis. This is the X-ray pre-op. On the right-hand side, we have our baseline recording. So this is the first time we saw the patient. And then over subsequent months leading up to surgery, we can see that the evoked potential gets smaller. A nice way of seeing how that VP deteriorates is that if we superimpose the baseline recording over the subsequent follow-up recordings, we can see it's predominantly the descending limb of the P100 that seems to get eroded. When the child had a vault expansion 5 months after testing, after surgery, we can see that the P100 is very similar in morphology to our baseline recording 15 months prior. And then interestingly, 14 and 18 months of follow-up, we can see that the P100 continued to improve in amplitude. So although this response at our baseline recording was within normal limits, there may have been already deterioration going on at that point. So if we had tested 5 months earlier, the response may have been bigger. So we can use it to monitor function. As I mentioned, it's very good for intraocular differences. This is a 5-year-old female with a traumatic neuropathy due to a fall. She hit the curb. She had a non-displaced left frontal bone fracture. She was quite difficult to assess clinically. They did manage to get a vision, which was 20/20 in the right eye and 20/30 in the left. We considered doing pattern ERGs, but she wouldn't tolerate any corneal electrode close to the eye. The fundus appearance was kind of unremarkable, but when we look at the VEP, these are to different check sizes, 100, 50, and 25. The right eye is dashed, and we can see a well-defined N80 and P100, evident to different check sizes. However, the affected eye, you can see is significantly reduced in amplitude across all check sizes, and then increased in latency. So showing that macular pathway dysfunction was quite significant. We can also observe changes in the morphology of the responses. And here we have a 3-year-old girl with bilateral optic atrophy. And what we see here is instead of one peak around 100 milliseconds, we're getting this bifid or W wave where we have 2 peaks. An earlier peak at 70 and then another one at around 130 milliseconds. And this distribution usually suggests a dominance of the paramacular components, and we see it with optic atrophy, maculopathy, and early signs of demyelination. So anything that's affecting that central macular pathway, we can see this W wave here. In terms of changes in morphology, again, this is a child who we're monitoring for raised intracranial pressure. And at 12 months of age, we had a nice P100 reproducible at around 100 milliseconds. 6 months later, the child comes back. The responses seem a bit more variable. And there's a suggestion that the P100 has increased in latency. And it's only until we consider that the child was slightly looking down rather than looking at the central fixation that we realized that if we got the child to look to the top of the screen, we had a well-defined P100. And then when we got the child to look to the bottom of the screen, we saw an inversion. And again, this inversion of the P100 was shown, early 70s. And what we find is that the inferior field is closer to the tip of the occipital cortex, and we get this very nice, well-defined P100, while the superior field is deeper down the sulcus, and we can see an inversion of the P100. So sometimes when we see changes in morphology or increases in latency, it's important to see exactly where the child is looking. We usually use closed circuit television, and we'll get the child to have a recording looking to the top of the screen and the bottom and alternate and see whether we can get that response to flip in polarity. One of the other things we do is that we use a slightly larger screen, and we do this to ensure that even though the child may have some fixation instability, as long as we're stimulating that central 14 degrees, hopefully we'll see less of this inversion as the child looks slightly up or down. So as we go on our recordings, because we have more than one electrode on at the back of the head, rather than just looking at the morphology and timing of the P100, we can look at its distribution across the back of the head. Pattern reversal is said to have a paradoxical lateralization. And what that means is when we stimulate one hemisphere, for example, when we stimulate the right hemisphere, because of the orientation of the dipole, it projects to the left and we pick up the response over the left. And vice versa, when you stimulate the left hemisphere, it projects to the right and we pick up the response over the right. If we're considering a chiasmal or hemisphere problem, in the older children, we can do hemifield stimulation. And when we stimulate the right half field, we have a positivity ipsilateral over the side of the field that's stimulated, and then a negativity over the contralateral side. And this is the paramacular component. And then if we switch over and do left hard field stimulation, that positivity shifts from the right to the left, and we pick up the IP100 over the left and a negativity over the right. However, when we see asymmetries, especially in children, we need to consider all the things that can result in an artifactual asymmetry. We spoke about poor fixation. There can also be things like head shape and dipole orientation. So with regards to head shape, this is a child where we recorded flash VEPs, and we can see that there's a well-defined positivity over the right occiput. However, over the left, there's this broad negativity. And this was similar for each eye, so suggesting a homonymous asymmetry consistent with a right hemisphere deficit. But in fact, when the child had an MRI scan for a different reason, we can see that the child has normal intracranial anatomy. And it's purely due to the midline shift and slight distortion of the skull at the back of the head that can result in these asymmetries. The next one is cortical orientation. This was a child who was slightly older, and we were able to do hemifield stimulation. But when we did full field stimulation, what we saw was the response over the left occiput was flat. And it's interesting to see how many units or people do hemifield stimulation in young infants. One of the advantages of when you do hemifield stimulation is that the technician who's helping is able to stand in the occluded field and point or use a small toy close to the fixation point. And then using closed circuit television, we're able to only record when the child is looking at that central point. So anyway, in this particular case, when we stimulated the right half field, as you'd expect, there was a nice positivity over the right occiput. And then you can see the well-defined negativity. We were expecting the left half field to be flat. However, the P100 was well-defined and quite comparable to the right half field. And it's only when you superimpose the left and right half fields that you can see there's a summation of the waveforms of the left and right half field here, while you get cancellation over this left occiput. In some work we did a few years ago at Great Ormond Street, we looked at all of the children who had full field asymmetries, who we recorded half field responses. And to our surprise, 50% of the children with significant asymmetries during full field stimulation had completely normal half field responses when we recorded the ipsilateral P100. And also in the majority of those who had normal half fields, the asymmetry due to the full field asymmetry was due to a symmetrical left half field, as in this case here. When we look at the anatomy, that kind of makes sense. Our brains aren't symmetrical, and in 80% of normal right-handed subjects, the gray matter volume in the left hemisphere is larger, and it protrudes over the right hemisphere. Because of that, when we stimulate the left hemisphere, the paradoxical lateralization is exaggerated, and we get a good response over the right and a negativity over the left. However, when you stimulate the right hemisphere, the response and the orientation of the dipole is more towards the midline, and therefore you get a more symmetrical response. And again, this was shown in the late 80s, how we can have these asymmetries in our hemifield responses from normal cortical asymmetries. So we spoke about the range of ages of children, and some of these infants obviously are not going to be able to do hemifield stimulation. So how do we determine if an asymmetry that we see is artifactual or not? Well, we can use the knowledge that the pattern reversal VEP is paradoxical. And again, when we stimulate the right hemisphere in this example, we pick up a response over the left. If we now compare the results to the evoked potential to pattern onset, what we find is that the pattern onset response is not paradoxical. So when you stimulate the right hemisphere, we pick up that asymmetry over the right. So in a child who isn't able to do hemifield stimulation, if we recalled pattern reversal and pattern onset responses, if there is a real hemisphere problem, in this example, a right hemisphere, with pattern reversal, the response will be larger over the right. However, with pattern onset, the response will be larger over the left. There's been a recent case series by Oliver at Great Ormond Street that showed that you can use these pattern onset and offset responses to identify hemisphere abnormalities. And he showed that the pattern onset didn't have a paradoxical lateralization. However, the offset response behaved in the same way as pattern reversal. The other reason why we use pattern onset offset in our practice is that it's quite robust to blur. So children with functional visual loss find it more difficult to defocus. And as a result, sometimes when we have degraded pattern reversal VPs, we'll have these well-defined pattern onsets. And in this illustration on the right-hand side, if you consider the moving red spot, the eye position of a child with nystagmus, again, as their eye is moving, as it changes from the pattern to the uniform gray square, there's always a 50% contrast, whether it's from white to gray or black to gray. So we can get quite nice evoked potentials in children with this marked nystagmus. So we've spoken about homonymous asymmetries and the artifacts that may produce them and cause us problems. The other type of asymmetry is a crossed asymmetry. And we can have too many fibers crossing. And this is usually the case in children with albinism. And here we have a schematic of stimulating the left eye, more fibers cross and stimulate the right hemisphere. And as a result, the pattern reversal response is larger over the left occiput. When we stimulate the right eye, too many fibers now cross over to the left. And now, because of paradoxical lateralization, the response switches and is larger over the right occiput. And it's this crossing of the response that we're interested in from one hemisphere to the other, depending on what eye we stimulate, it gives the name crossed asymmetry. Just like you can have too many fibers crossing, you can have too few fibers crossing. So in this child here, we stimulate the left eye, and the response is larger over the right occiput. And that must be due to, when we stimulate the left eye, the ipsilateral hemisphere being stimulated. When you stimulate the other eye, now the positivity is over the right occiput, and this must be due to, again, ipsilateral stimulation of the pathway. And this was due to a child with achiasmia. And here in the MRI scan, you can see the clefting of the chiasm in the middle. So when we see crossed asymmetries, we shouldn't always just think of albinism. A crossed asymmetry always points towards the chiasm, and then it's the distribution of the VEPs that tell us whether there's too many fibers crossing or too few. So far the child's been in the chair around half an hour, a few minutes to put the electrodes on. We spent about 20 minutes doing our evoked potentials. And from this recording, which is the least invasive, it's given us information about macular pathway function. It's given us a guesstimate of visual acuity. It's identified any significant intraocular differences, and it's also helped us to see whether there's any hemisphere or chiasmal dysfunction. And what that leaves us is around another 10 to 15 minutes to record skin ERGs. There's many papers now that show that the skin ERGs are similar in morphology to those obtained using corneal electrodes, and it's purely a scaling factor. So we use disposable electrodes just placed below the lower eyelid on the cheek. And what's important is that when we're doing the recordings is to get the child to look down towards the stimulator. And this puts the eyes in the optimal position to pick up the response from our electrode. And sometimes in these tiny babies where we can't control their eye position, when their eyes roll up, we can actually see an inversion of the ERG, it flips in polarity. The reason why we can do our recordings in 10 to 15 minutes is that we don't dark adapt these children. And we rely on spectral filters when we used to use the grass stimulator to isolate the rods. And in this graph here, you can see the broad blue color is the grass filter. And these narrower bands are the filter settings of the LEDs in the new ColorFlash. So by recording using skin electrodes and a handheld stimulator, we're able to record ERGs that are very similar to the ISCF standard. So we have a rod-driven response, our mixed rod cone, we have a scotopic cone, our photopic single flash, and then our flicker. And just to show you how we can acquire these are the live recordings of this little child on the right, and we can see the rod response build up. And just to save time, I'll also show the mixed rod cone response being recorded. So we can see the muscle activity on top of the waveforms that is being averaged out due to signal averaging, but we can definitely see a nice rod-driven response with minimal A wave. And then when we change the stimulus, the mixed rod cone response becomes better defined with an A wave and a B wave. The other thing that we do is the sequence of how we present these stimuli, which is different to the ISCF standards. So the first stimulus we do, which is in the ColorFlash protocol, is that we record the mixed rod cone ERG. And again, the reason we do that is that if for some reason the child, once we've obtained this response, puts their hands up and doesn't cooperate anymore, it provides us the most information. If there was a marked rod problem, this mixed rod cone response would look more like a cone response. And if there was a cone problem, it would be shifted and looks more like a rod response. The second stimulus we typically use is the red. And we use this for two reasons. The first reason is any child with a cone problem struggles more with a photopic flash, a bright flash during photopic testing. And they seem to tolerate a red stimulus photopically a lot better. So by obtaining this, we can get an idea of how the cones are working during scotopic conditions. The third step is the dim blue flash that we do, and you saw the recording being obtained over here. Step 4 is the maximal flash with a large interstimulus interval, and we're looking predominantly at the rod A wave. We then turn the lights on, record our cone response, and then our 30 Hertz flicker. So the people who've been using the grass stimulator are very used to it, and we're very comfortable using it. it was fantastic in what it did. It had a very bright stimulus, a very short duration, but it had some drawbacks. The illustration on the left here is a photograph of when the grass stimulator flashed. And you can see it had a quite narrow hotspot in the middle, and then an asymmetrical distribution around the bowl itself. And that was very similar when we used colored filters or not. In comparison, when we started using the ColorFlash, we could see that there was a uniform intensity across the face. And what enabled us to do was that we could hold the ColorFlash in front of the child and know that we had a uniform intensity stimulus stimulating the whole face. Therefore, we didn't have to really concentrate on where that hotspot was. And when we did our study, although the purpose wasn't to get identical responses between the two stimulators, what we did show is that you could get comparable ERGs to the different grass settings during photopic and scotopic testing. The major advantage of the ColorFlash, and we use it whenever we see an atypical morphology response, is the ability to record on-off ERGs straight away after our flash ERGs. And this is just a control subject, and we can see that we have a cone A wave from the photoreceptors, the B wave from the on bipolars, and then the D wave from the off bipolars. Using this handheld, this is one of our subjects, and we can see that we have the A wave, a well-defined D wave from the off bipolars. However, the negative ERG is due to the on bipolars not working properly. And this was a child with complete congenital stationary night blindness. So again, within this 45-minute period, we've been able not only to assess the visual pathways, both macular and general pathways, we've been able to look at the ERGs, both to single flash and then to prolonged flash stimuli. I think all of us who see some of these very young children with either cataracts or corneal opacities, we need to be aware of the effect of the opacity. So these are some flash ERG recordings using skin electrodes from the left and right eye in these three subjects who have significant corneal opacities. And what we see is well-defined A waves. However, the B wave is significantly reduced. And if we just stopped here, we may think that the child has an inner retinal problem. Then that might go into the decision tree of whether to attempt a corneal graft in these children. But what we see is when we reduce the intensity of the stimulus, we can see that the morphology of the ERG normalizes. And we see this in adults when we're doing iScav recordings. And basically the corneal opacity has just pushed the stimulus over the photopic hill. And the opacity has acted as an excess scattering device, therefore making the response, making the stimulus be brighter than it actually is. So just something to be aware of. There isn't time to go in kind of the different types of ERGs we get with different specific conditions, but it's enough to say that they're either reduced in amplitude, both either for the rods and cones, they're increased in implicit time, or they can be changed in morphology. So within that 45-minute period, we've been able to carry out all these investigations, clean the electrodes off, and send the child on their way. They're not always happy. Sometimes by the time we get to the flash monoculars, which is the very last thing they do, all the texts here will tell you that we do get a lot of screaming sometimes. So just summarizing, with the VEPs within this 45-minute protocol, we're able to determine whether the abnormality is affecting one eye or both. If it's affecting one eye, it's usually a dense amblyopia or an optic nerve problem. If it's affecting both eyes, the VEPs can either be symmetrical or asymmetrical. If they're symmetrical, it's due to bilateral visual pathway dysfunction. If they're asymmetrical, we can have two types of asymmetries, either uncrossed, and that pushes us towards a hemisphere problem, or we can have a crossed asymmetry that pushes us to the pathology at the chiasm. And depending on which way the crossed asymmetry goes, it's either too few or too many fibers crossing. And with our skin ERG protocol, we can determine whether the rods are affected and the cones, or if it's mainly affecting either the cones or the rods. And if we have some abnormal morphologies like negative, we can go on and do prolonged flash ERGs within the same setting, see whether it's affecting the on or the off bipolars. So I'm going to finish there, but the main thing I want to do is thank the technicians who acquire this data, who develop a skill of working with these very young children, being able to play with them, get them to attend to stimuli, and actually allow them to put all these electrodes on. So thank you.
Excellent. Thank you very much, Alki. Excellent talk. And Natalie,
Yes.
let's turn things over to you and see what sort of questions we have.
All right. So we got a question. How do you achieve that babies maintain fixation? How can you tell if they're fixating, or how do you compensate for flipping all over? I think.
Yeah. So I mean, fixation is a very important point, and what we do is we have closed circuit cameras in all our labs, and the person doing the recording is able to see, using the corneal reflection, of where the child's looking. So we're able to start and stop the recordings every time the child moves away from that central fixation point. Sometimes children need coaxing to look at the central fixation point, and we have small toys that grabs the child's attention. It's taken to the fixation point, and then the technician moves their hand out the way. So it's that kind of continuously bringing that child's attention to the middle of the screen, us looking using closed circuit television to ensure we only acquire data when they're looking. Because it doesn't take many epochs of the child not looking to degrade the evoked potential that you're recording. I hope that answers it.
Natalie, you're on mute.
I muted myself to blow my nose.
There you go.
I do this every single webinar without fail, sorry. Another question regarding the VEPs you're discussing, are those 3-channel VEPs?
Yes, they are.
And then follow-up question, is one eye covered when you do hemifield stimulation? Do you do those monocularly or binocularly?
Typically, we always do monocular hemifield stimulation. If a very young child comes in, maybe 2-3 years of age, and we know that they have a hemisphere problem, the technicians do attempt to both eyes open hemifield stimulation.
Another question, do you see any polarization effects to flash in these skin patch, excuse me, these skin patch electrodes?
The polarization of the disposable electrodes?
Yes, the sticky pad electrodes, basically.
I'm not sure what we mean by polarization, but they're silver chloride disposable electrodes. They behave very similar to kind of the non-disposable ones. If we keep the impedance of the skin at an acceptable level, it's fine.
They do.
I'm not sure about the polarization, sorry.
They do also have he's clarifying electrical polarization. Do you mean like a photoelectric or photovoltaic effect? Hoover, is that what you're referring to? Yeah.
Hello, Ruth.
Yes, he is. So they also do have a sort of fabric-y, opaque covering over them that does protect them from the flash to help prevent that from happening. So
yeah, so we usually see that photoelectric effect if we have unbalanced electrodes. So sometimes when we the reference electrode is usually at a better impedance. Sometimes if a child is struggling and the impedance of the electrode that we're recording the ERG from it is slightly higher, we do see that. It occurs at 0 milliseconds. It's an artifact, but sometimes that's all we can get. But we do use Coban, so we do cover the reference electrode with that Coban. It gets incorporated.
Okay, this is a good point to work in one of my questions. If you could add just a little bit more about skin preparation and when you know you have enough and not enough, and what technique you use for your ERG electrodes.
So we usually use a cotton ball with new prep, and after about 4 or 5 wipes, not vigorous rubbing because that kind of burns and it hurts the kids, but just kind of wiping of the cheeks usually brings the impedance down to about 5 hertz, 5 kilohms. If we have somebody who's got a bit of an oily skin, just before we use the new prep, we'll use an alcohol wipe just to wipe the skin to get rid of the oils before we abrade the skin. One of the issues is actually when we have new eager techs, is that they scrub so much that our impedances start being kind of 1 or 2. And what we find is that, you know, the difference between 1 and 2, they're balanced by quite a lot. And we always need that balance of 4 and 5, which is less of a difference.
Good point.
I have another question. Can you talk a little bit, I know in the United States, this is less common elsewhere in the world, but not unheard of. There are several sites that put babies under anesthesia in order to do electrophysiology. Is that something that you have much experience with, or is that something you do or recommend?
I think because of the protocol that was taught by Tony Chris and the protocol that I used with Dorothy Thompson at Great Ormond Street for many, many years, I think in the 20 years I was there, I think we took 5 children, and that's maybe an over-exaggeration, to theatre. There is typically, it's only in those very, very difficult cases where the children are quite delayed and they may have a retinal detachment, and the surgeon really wants to know, is it worth salvaging and doing this kind of heroic surgery? And those are the ones that we take to theatre and sedate. And what, the other important fact is that when we do take children to theatre, we do an ISCF protocol. So we dark adapt for 20 minutes, we do our recordings scotopically, we then light adapt, and then do the recording. So we would never take somebody to theatre just to try and do a recording without doing the ISCF standards. So it's only those really difficult ones that we've tried maybe 2 or 3 times using skin electrodes to answer the question that would take theatre. So my experience of actually doing recording in the theatre is very limited.
Okay. And then kind of a follow-up question to that. Since you don't typically put your young patients under anesthesia to get your ERG and VEP recordings, do you have any tips or tricks for getting young children to cooperate, especially for those in the audience who may have a primarily adult practice, but sometimes see young children and don't have that experience? Is there anything that you could offer them that might help?
Yeah, I think, again, it depends on the age group. So the very small ones, kind of the babies in arms, once we put the electrodes on, mum can feed the baby either with a bottle, and we can get them to relax. Sometimes even if they fall asleep and their eyes are in the right position, you can hold the eyelids up just gently and use the handheld stimulator. I know I've got 2 kids, but the term the terrible twos is a very true thing. And then sometimes there's nothing we can do for those 2-year-olds, and they're going to scream. And we have 3 technicians in there, 1 holding the hands, 1 holding a toy, 1 rattling. And it's hats off to the technicians who are in there sweating with those terrible 2 children. With the older ones, again, I think when you do pediatrics, one of the things I say to all our new technicians is that engagement with the child starts when you see them in the waiting room, and you talk to them and you tell them that nothing's going to hurt and things may seem strange. And I think you'd be surprised how much more compliant a child is when you tell them about the tests in kind of age-appropriate language. And before you put the electrodes near the eyes, or before you even rub the skin, you can take their little hand and you can rub on their hand and show them it's not going to hurt. The cream may feel cold. So a lot of it is that kind of interaction between the technicians and the child from the onset. Again, in the waiting room, you're talking to them, trying to pick up whether they like Frozen or do they like Mutant Ninja Turtles, and that's the conversation that you have with them when you bring them into the room. and you base the conversation around that. I'm not going to say this is always easy and every child comes in, jumps up on the chair and sits there. But success is that interaction with the child, and also the success is the interaction with the parents. Sometimes you get a feeling from a parent whether we're going to have a good recording or not, because you know whether they're kind of invested and able to go along with the kind of recordings that we want to. So getting the parents on board is very important, but also that bond you make with the child.
Excellent. We have some tips from the chat that I'd just like to add into this. Hoover mentions that he has good experiences gamifying the process with children, and Becky mentions that she's had some success mimicking the setup on a stuffed animal that they brought with them, which is a great tip I haven't heard before and am going to be passing out. Thank you.
Yeah, sometimes people ask why you need 12 disposable electrodes to do one recording, because they're all over, you know, animals and the parent's face and the technician.
I have one follow-up question for you there. Do you do multifocals on kids as well?
The youngest that we can probably obtain a reliable multifocal is probably a cooperative 6-7-year-old. And again, that's a generalization. I said yesterday that somebody asked, when do we do pattern ERGs in children? And sometimes I'm not going to say girls are more mature, but we do have, in my mind, these kind of very cooperative 4-year-old girls who allow you to put detail electrodes in, and then you get a love recording. And then a 16-year-old boy will walk in, and you think this is going to be a lovely walk in the park, and he's crying, stamping his feet, won't let you put the electrodes in. So I think it's an individual basis, but multifocal definitely, because of the fixation and sitting on those machines aren't easy. It's like doing a visual field. It's, you know, sometimes when you ask them, are you comfortable? Yes, they are, but 30 seconds into it, their back's hurting and they're kind of moving about. So I would leave it to kind of cooperative 6-7-year-olds.
I'd like to add on to that. It depends not only on the child, but the child that day. I was speaking to a site in Singapore last year and asked them a similar question: what's the youngest that you do? And they said, oh, we did actually this incredibly beautiful multifocal on a 4-year-old. We couldn't believe it, but she was a dream. She was just the greatest little kid. And then she came back a year later. We tried to do it again, and she kicked and bit us all. So there was absolutely no doing. So it very much depends on the child themselves. So
yeah, just one quick follow-up on that. In some cases, there may be no plan B, but are there any plan B options then, Alki, for some of the children that you want to do a multifocal on where that doesn't work? Do you have a fallback position or not really?
I think in those kids, the fallback would be to do a pattern ERG. So if I've thought about doing a multifocal ERG in a child, we definitely could do a pattern ERG in them, because the electrode is the same. So if we've managed to get a detail electrode in, the fallback would do a pattern ERG.
Very good.
We don't usually do the fallback because in the sequence of things that we would do, I wouldn't really do a multifocal unless I've done a normal pattern ERG first anyway.
Okay.
And then we've got another question in chat. Can we use the adult binocular Ganzfeld if we don't have the handheld stimulator? I don't know. Jeff?
I thought it was a technical question, but do you know what? I suppose you could. There's 2 handles on it, but you'd need to unmount it. I never have, and it's an expensive thing to drop.
I guess my answer would be pretty similar. Let's see if we can work with whoever asked that to find a way for them to have a color flash at some point.
Great. Any other questions? Feel free to or comments or anything along those lines.
If we have a pause, Natalie, let me work one other question in that I had for Alki. Alki, can you talk a little bit about your decisions for how many sweeps per step you make in the basic protocol, and then any adjustments you might make based on conditions that you're seeing with the child?
Yeah, again, what we try and do is that all the technicians who are doing the recordings, they have their own signal to noise ratio working in their head. And the reason I say that is that sometimes you can have considerable artifacts, maybe at 5 milliseconds or at 200 milliseconds, but the P100 is well defined. And usually they stop recording when the morphology of the P100 stops changing. And that may be 25, 40 dots. What we do, however, is that we make multiple recordings and ensure reproducibility. So maybe 3-4 trials.
Excellent.
What we do find is if you just allow the system to keep averaging and get your 200 sweeps, it's very easy for a child to, even though they appear to be looking at the screen, to become drowsy. You see the alpha rhythm come into the ongoing EEG, and then you see the VP actually starting to blur, change in morphology. So I don't think it's beneficial to carry on and record your 100 epochs in every child for every sweep.
Those are great points. And for those on the webinar that don't have a Diagnosys system, all of our protocols come with a standard number of recordings per step, and you can just run those. But then as Alki is mentioning, you can certainly adjust either downward, or you can always add more sweeps in quite easily in our software as well, on the fly during the test.
What we also do is we record all of the epochs. And even though you have the artifact rejection ratio set, so we exclude anything that is too big, we always go through the data because it doesn't exclude anything that's too small, like a flat line or something moving at an angle. So we'll go through and actually then select some of those outliers that may be affecting the overall average, and then see if there's any high frequency artifacts in there that, again, that are just below the amplitude rejection ratio, just to try and clean up that waveform.
That's a really good point. And so for current Diagnosys system owners, including Alki, I'm not sure that I've mentioned this to you, in our newer software, we actually have a way of automating the process you just mentioned of deselecting smaller sweeps. So that's something we'd be happy to talk with anyone about as a kind of a new prototype capability that we're building into our software.
So just to bring this full circle, Alki, at the beginning of the presentation, you had asked us if we'd had a lot of interest in the ColorDome shields, which, for those who are unaware, we have some plastic shields that can basically prevent stale, possibly COVID infected air from collecting in the ColorDome. And Wanda just put a note in chat saying that the new shield also prevents children and infants from spitting into the dome, which is a plus. So,
COVID or not, it's a benefit.
Yeah, trying to extract Cheetos from the ColorDome is a bit difficult.
So, Henry, yes, the Gansfeld stimulator, all of our Gansfeld stimulators can do SMNL specific recordings. All three of our ColorDome, ColorBurst, Gansfeld stimulator, ColorBurst, ColorFlash, ColorDome, Gansfeld stimulators do have red, green, and blue LEDs. You can selectively stimulate any of those. And with that, that's 12 o'clock, so that brings us to the top of the hour. Again, thank you so much. We've gotten a lot of thanks, Alki, in the chat. I don't know if you've been reading that. We've gotten a lot of thanks and a lot of comments saying that this was incredibly helpful. So I'd like to join the people in the chat for saying thank you so much for joining us today. This was really an incredible talk. Very
pleasure to speak with you.
So again, for those of you who attended, found it useful, we will be sending out a recording of this. If you didn't put your email address in your when prompted initially, if you could put your email address in there, or possibly put it in chat, make sure that we can get that to you, or send us an email after the fact. And other than that, thanks so much.
And my email is online, so if anybody wants to email me specifically, there's no silly question. I always ask silly questions, or if there's something more in depth.
Very good. Excellent. Again, thank you, Alki, very much. And thank you for everyone who joined us today. A fantastic session. Everyone have a great weekend.
Bye.
Great.